Hello, this is Franco Demonte, and I'm happy to be narrating this portion of our chapter, Neoplasms of the Paranasal Sinuses. I want to first off thank my co-authors, Idara Edem, Sean Raza, and Keenan Al-Khalali, who have helped tremendously in the preparation of this manuscript. The sections that I'm going to narrate are contained under the heading Surgical Management, and I will start with craniofacial resection. For a craniofacial resection, the patient is placed in the supine position with the head supported by a horseshoe headrest or affixed in a rigid cranial clamp. A bicoronal incision is carefully opened to expose the galea. The galea is opened sharply and dissected from the underlying loose connective tissue. Care is taken to preserve the anterior branches of the superior temporal arteries. The scalp flap is reflected anteriorly by dissecting immediately below the galea poniotica, thus maximizing the thickness of the loose connective tissue layer overlying the periosteum. The posterior aspect of the scalp flap is undermined to maximize the length of the pericranial flap. Incisions are made bilaterally through both superficial and deep layers of the temporalis fascia, approximately 1.5 centimeters above the zygomatic process of the frontal bone, and carried posteriorly for approximately 2 to 3 centimeters. Incisions in the periosteum are made at the level of the superior temporal line bilaterally, extending posteriorly from the previously described fascial incisions. These incisions are carried under the posterior scalp flap and then joined across the top of the head to circumscribe the pericranial flap. The pericranial flap is then elevated and reflected anteriorly. With a sharp periosteal elevator, the pericranial tissue is dissected from the orbital rims and from the zygomatic process of the frontal bone. The anterior portion of the temporalis muscle is dissected from the temporal fossa and reflected posteriorly. This gives access to the keyhole regions bilaterally. Entry holes are placed in both keyhole regions and at the superior sagittal sinus. A free bifrontal craniotomy is elevated. Because the majority of the work will be in the midline, the bone flap is extended inferiorly to just above the frontonasal suture. Following elevation of the bone flap, the frontal sinus is completely cranialized and demucosalized. The dura is elevated to the level of the crista galli and over both orbits. The crista galli is removed with a high-speed drill under magnified vision. The dural sleeves extending through the cribriform plate are cut, and the dural elevation continues posteriorly to expose the frontal sphenoid suture. At the posterolateral aspects of the cribriform plate, in line with the frontal sphenoid suture, the posterior ethmoidal artery is identified. The posterior ethmoidal arteries are coagulated and divided, and further elevation of the dura is possible. The dura is then primarily repaired. If needed, a dural replacement graft is placed and microscopically sutured to achieve a watertight closure. With the high-speed drill, osteotomies are made in the floor of the anterior cranial fossa. If the tumor involves the entire ethmoidal sinus complex, these osteotomies should be placed through the medial part of the orbital roof in order to enter the orbits bilaterally, lateral to the lamina papyracea. The posterior osteotomy should be at the level of the frontal sphenoid suture. This suture overlies the posterior ethmoidal air cells in most people, although it may overlie the anterior part of a large sphenoidal sinus. As mentioned, the posterior ethmoidal foramen is in the posterolateral aspect of this osteotomy. The exit of the optic nerve from the optic canal can be found approximately 5 to 7 millimeters posteromedial to this artery. From above, the periorbital membrane is dissected from the lamina papyracea bilaterally, and a small curved osteotome is placed medial to the orbital tissues. An osteotomy is placed at the inferior aspect of the lamina papyracea, just where the bone turns to form the floor of the orbit. This osteotomy is placed bilaterally. An osteotomy is then placed across the lamina papyracea posteriorly, with half the osteotome being intraorbital and half within the posterior ethmoidal sinus. The posterior bony septum is then divided with a curved osteotome. The anterior osteotomy is across the base of the frontal sinuses and enters into the nasal cavity. The anterior part of the nasal septum can be exposed here, and this is divided with heavy scissors. This allows for the removal of the entire specimen transcranially. If the tumor extends lateral to the medial third of the maxilla, or if the tumor extends into the anterior nasal cavity, Then a transfacial or endoscopic approach is used to free the specimen for removal. Residual air cells are removed and any involved or questionable periorbital tissue is resected. Small periorbital defects are well tolerated, but large defects should be repaired with temporalis fascia. The pericranial flap is then cut to the appropriate length and sutured to drill holes placed in the plenum sphenoidale and medial orbital roofs. Fibrin glue may be used to reinforce the dural repair and the edges of the pericranial graft. The bone plate is placed back in its anatomic position and rigidly fixated. It is vital to ascertain that the bone flap causes no compression of the pericranial graft. The pericranium should be able to move freely between the bone edges. Next, I will describe the endoscopic transcribiform resection. After administration of broad-spectrum antibiotics, the patient is placed in the supine position with the head fixed in a rigid cranial clamp. After registration with neuronavigation and a sterile prep, the nasal portion of the operation commences with raising a nasoseptal flap based on a sphenopalatine artery pedicle if the nasoseptal mucosa is uninvolved unilaterally. It is imperative that this flap is free of disease and confirmed with an intraoperative margin if necessary. In raising this flap, the mucosal incisions should be carried as superiorly, anteriorly, and laterally as possible to ensure the flap has the adequate length and width to cover any cribriform plate defect. At this point, a septectomy is performed to not only clear margins, but also to widen the fields to facilitate binarial access. At this point, the uninvolved sinuses are opened in a manner to identify normal anatomic landmarks circumferentially around the sites of disease. This will involve turbinectomies, maxillary antrostomies, ethmoidectomies, sphenoidotomy, and a draft 3 frontal sinusotomy. The techniques have been well described in the literature and are outside the aims of this chapter. These steps ultimately isolate the nasoethmoidal components of the tumor from surrounding structures prior to performing the skull base resection. Before commencing the cribriform plate resection, the anterior margin is defined by performing a draft 3 frontal sinusotomy. This technique delineates the posterior wall of the frontal sinus and identifies the cribriform plate at its anterior-most extent. The cribriform plate resection is initiated using angle drills and punches to develop osteotomies along the plenum posteriorly, medial orbital walls laterally, and the posterior table of the frontal sinus anteriorly. The critical step is also to detach the crista galli from the falx with the aid of a diamond drill. The dura is subsequently incised along the perimeter of the exposed anterior fossa dura. The diseased dura can then be removed and any intracranial component subsequently removed separately from the skull base. During this process, it is important to section the olfactory nerves distal to the specimen in order to obtain margins and safely free the specimen. If necessary, any bulky disease intracranially can be debulked using a tissue aspirator and meticulously dissected from adjacent brain. In the situation of brain invasion, a cuff of surrounding parenchyma is resected. At the completion of the resection, margins are obtained, most notably from the olfactory bulbs and the dura. Once a complete resection has been confirmed with margins, reconstruction of the anterior skull base defect is based on the principle of a multi-layer closure. This reconstruction typically commences with an inlay of a free fascial allograft or a collagen-based dural implant, followed by an onlay fascial allograft. At this point, a vascularized flap should be placed along the nasal side of the closure. The nasal septal flap is commonly used. However, salvage options include a pericranial flap harvested via a hemicoronal incision and transposed via a bony window at the nasofrontal suture into the nasal cavity and manipulated with endoscopic assistance. As with an open craniofacial reconstruction, the pericranial flap's robust pedicle and arc of rotation provide good coverage for defects extending posteriorly to the plenum. The risk of graft migration is mitigated by securing the flap along its periphery with pieces of Surgisil wrapped gel foam, and with rigid fixation in the form of a Foley balloon along the anterior-most aspect of the closure and nasal packing buttressing the reconstruction posteriorly. Next, I will describe our approach to the transmaxillary maxillary neurectomy. I should note prior to that, however, that over the 3 decades of performing craniofacial resections here at MD Anderson, there clearly has been a migration in the surgical approaches used. In the 1990s, the majority of resections were via both open transcranial and transfacial approaches, whereas in the 2000s we began gravitating towards a transcranial or transcranial endoscopic approach, and ultimately in the 2010s, pure endoscopic approaches have increased in frequency in our practice. The surgical access to the maxilla is obtained through a lateral rhinotomy, sublegal approach, or both. The amount of bone resected depends on the extent of the tumor and may involve a medial, inferior, or complete maxillectomy. The infraorbital nerve is identified and followed to the pterygomaxillary fissure. The nerve is dissected free of the adipose tissue and followed to the foramen rotundum, located at the top of the pterygoid plate. The foramen is widened with a high-speed drill to expose the dura of the temporal fossa floor laterally and the cavernous sinus medially. The medial temporal dura is dissected laterally off of the maxillary nerve in its course through the lateral wall of the cavernous sinus. The extradural dissection continues posteriorly to reach the anterior portion of the Gasserian ganglion, and the neoplastically involved nerve is resected. The technique of orbitectomy, as for cribriform plate resection, is somewhat beyond the scope of this chapter. However, I will describe it here. It typically uses a bicoronal incision with elevation of a pericranial flap. The temporalis fascia on the side of the orbitectomy is incised from the level of the superior temporal line to the root of the zygoma. Subfascial dissection exposes the lateral orbital rim and the entire zygomatic arch. Depending on whether the tumor is anterior or posterior in the orbit, the orbital rims may be left in place and taken as part of the specimen, or removed and replaced at the end of the operation. The temporalis muscle is carefully dissected from the temporal fossa and reflected posteriorly, making sure to preserve its blood supply. The greater wing of the sphenoid is removed with a high-speed drill, exposing the superior and inferior orbital fissures. The lesser wing of the sphenoid, which makes up the posterior part of the orbital roof, is left in place as the guide for the intraorbital incisions. Beginning just laterally, at the level of reflection of the temporal dura to the supraorbital fissure, the tissues of the superior and inferior orbital fissures are incised with cutting cautery flush with the bone of the orbit. As this cut progresses medially, care is taken to identify the ophthalmic artery, which is coagulated and divided. Then the incision continues through the optic nerve. A high-speed drill is used to go through the floor and medial wall of the orbit, thus entering the maxillary sinus and posterior ethmoidal sinuses, respectively. A bifrontal or unilateral frontal craniotomy is fashioned, and the subfrontal dura is elevated as previously described. The osteotomies are placed through the cribriform plate into the ipsilateral ethmoid sinuses if the tumor is entirely within the orbit, but into the contralateral ethmoid sinuses if extension through the medial orbit occurs. They may even need to be placed into the contralateral medial orbit if the entire ethmoid complex needs resection. An osteotomy through the remainder of the orbital roof completes the superior osteotomies. If the tumor extends posteriorly into the orbital apex, the lesser wing of the sphenoid, including the anterior clinoid, is removed and the optic canal is opened. The subclinoid internal carotid artery is identified, and the optic nerve and ophthalmic artery divided within the optic canal. Using a high-speed drill, an osteotomy is made through the floor of the optic canal into the underlying sphenoidal sinus. Care is taken to stay anterior to the anterior loop of the internal carotid artery. The optic nerve sheath is sutured to prevent CSF leakage. The transfacial approach is then used to perform either partial or total maxillectomy. If only a partial maxillectomy is required, this can be achieved completely through the circumorbital incision. If a total maxillectomy is required, a lateral rhinotomy and a lip split incision may be needed. Reconstruction can typically be performed using the pericranial flap previously harvested and the temporalis muscle with a skin graft. At times, a free rectus abdominis tissue graft is necessary. In our experience, there is no significant difference between these two reconstructive methods. The free tissue transfer is preferred if there is a large defect with significant dead space or if the blood supply of the temporalis muscle is deemed tenuous. Maxillary sinus tumors that extend through the posterior lateral wall and enter the infratemporal fossa may require lateral approaches in order to achieve full excision. For this region, a preauricular incision is used, which may be extended across the scalp into a full bicoronal or three-quarter bicoronal incision, depending on the anterior exposure needed. The incision may also be extended down into the neck to allow for parotid and neck dissection or mobilization of the mandible. Once the scalp has been reflected, an incision is made through both the superficial and deep layers of the temporalis fascia from approximately 1.5 centimeters above the frontozygomatic suture down to the root of the zygoma. Dissecting subfascially protects the branches of the facial nerve and exposes the entire zygomatic arch and lateral orbital rim. The tripod of the zygoma is freed by osteotomies through the root of the zygoma, the lateral orbit, and the body of the zygoma. It can be pedicled inferiorly on the masseter muscle or removed entirely as a free piece of bone. If a more extensive exposure of the lateral skull base, including exposure of the carotid artery, is necessary, the posterior osteotomy may be made through the glenoid fossa rather than the root of the zygoma. The temporalis muscle is dissected from the calvaria and reflected inferiorly. Mobilization of the zygoma allows the muscle to be deflected inferiorly for a greater distance, which allows direct exposure of the base of the middle cranial fossa and the infratemporal fossa. A subtemporal craniectomy is then performed, opening the superior and inferior orbital fissures, the foramen rotundum and the foramen ovale. If further medial exposure is required, the middle meningeal artery is coagulated and divided. In most patients, removal of the bone between the first and second and third divisions of the trigeminal nerve exposes the lateral sphenoid sinus. The pterygoid plates are well exposed and can be removed in their entirety. This exposure now allows resection of tumors within infratemporal fossa or lateral sphenoidal sinus extension. This approach also allows elevation of the medial temporal dura for exposure and resection of the trigeminal nerve should it be involved by perineural tumor extension. This is generally combined with an anterior or anterolateral approach to resect the primary tumor. Subcutaneous fat is used to obliterate the opened sphenoidal and maxillary sinuses. The muscles and bone are returned to their anatomic positions and rigidly fixated. Should a large resection be necessary, a free tissue transfer is used. Thank you for listening, and I now return you back to our chapter on neoplasms of the paranasal sinuses. Thank you very much.